Alright, so today's notes are over heart actions. And this first slide is basically stating that the chambers of the heart kind of work together in a really coordinated fashion. And there's two words to kind of describe it. The first one's called systole, and this is the actual chambers, the atria or ventricles doing a contraction. And then diastole is the relaxation of those chambers. So a cardiac cycle is the chambers actually contracting and then relaxing, and we call that a complete heartbeat. So it's kind of one contraction followed by one relaxation, and that's what this picture is showing here. So the diastole, the relaxations, when we can actually fill the chambers with blood, and then the systole is when we're actually pushing that blood out, up and out of the chambers through the different vessels that it needs to go through. So pressure within those chambers kind of rises and falls. So when there's too low of pressure, the AV valves open up and then blood starts to fill first the atria. And then when the atria are full, those AV valves, other way around, the ventricles fill first. And then once those are full, the AV valves will kind of snap shut and then the atria will begin to fill up. So once the ventricle kind of just gets to a certain point, that valve picks up on it and snaps shut. So when those ventricles start to push, semilunar valves are going to open up. So that would include your pulmonary valve and the aortic valve. And so then, now that these AV valves are shut, we can kind of do that contraction and blood isn't going to go backwards in the system. It's only going to go forwards out through those vessels. Pressure drops again, and so semilunar valves are now going to close, and then the AVs open up again, and we kind of start all over. So ventricles fill first, snap the AV valve shut, fill the atria while we're kind of pushing the blood up and out of the heart. And that's kind of what this is showing. So here's that diastole where we're actually filling the ventricle chambers, and then that pressure gets to a point where these snap shut, and so once those snap shut, the semilunars open up, and then we can actually pump blood up and out of the heart, and that's systole. Your heart makes a pretty distinct noise, and we call it a lubbed-up sound. And what that noise is actually the vibration of the valve snapping shut. So the first lub occurs when those AV valves snap shut, and then the second dup occurs when the semilunar valve snaps shut. So your heart kind of does a very quick concentric, like lubbed-up, lubbed-up noise, and that resting period between them is when the heart is actually kind of refilling there. And so you're just kind of hearing both sets of valves close really close together. And again, that's what this picture is showing. So the first lub, AV valves, and then the second one is the semilunars, so aortic and pulmonary. And then this slide is just talking about how the heart contracts all together as a unit. And so we kind of have this, what we call the cardiac conduction system. It's basically a bunch of branching fibers that extend all the way through the heart, and they cause your heart to beat together all as one unit. And so it's a very coordinated fashion. It all begins with this structure right up here called the SA node or sinoatrial node. It's basically embedded in the epicardium, so it's kind of embedded in the wall there, and it sits right up at the top of the right atrium, right where the superior vena cava comes into the heart. And again, it's going to receive an electrical stimulation from the brain, and so your brain really kind of regulates how fast the heart is pumping. But once it gets the stimuli, it generates an impulse, which is going to then cascade down to the rest of the heart. And so we call this the pacemaker of the heart. So the SA node is the pacemaker, and it really sets the rhythmic contractions then for how your heart's going to beat all together. If somebody's having an issue with this SA node, we do have like artificial pacemakers that can get put in. There's different ones, but usually it involves like basically a machine part that kind of gets put in, and then it's linked via a wire. Sometimes they're wireless and they kind of link to the outside of the body, and that kind of has to be controlled, and then they only last so long. So sometimes we have to go back in and kind of replace those. I think it's about every 10 years that artificial pacemakers would need to get replaced. And once they send out their signal, it goes next to this structure here called the AV node, stands for atrioventricular node. And that one sits in the septum here, right between your two atria, again, embedded in kind of the wall of the muscle there. And there is a little bit of a delay from the SA to the AV node, and that just allows your atria to basically fill up with blood, to do a little contraction to fill the ventricles with blood. And so that it's just enough of a delay where we're allowing that blood to kind of get down in there before we do the contraction. And then that extends down this structure called the bundle of His, or AV bundle. It's a group of specialized fibers that sit down here in the interventricular septum, and then they branch off into the left and right side. And they're made of these special fibers called Purkinje fibers. Those Purkinje fibers kind of spread out into the papillary muscles extending off the walls of the ventricles. And they do a very coordinated squeezing motion. So it actually starts down low here at the base, at the apex of the heart. And it basically kind of squeezes the heart, almost like you're wringing out a towel. And it'll start the contraction down low, and then it'll kind of work its way up and up the sides. And so what you're doing is you're actually forcing the heart to squeeze the blood up and out. So instead of the heart just doing like a weird convulsion type situation, it does a very coordinated squeezing to force that blood out of the aortic valve and out of that pulmonary valve. So kind of up and out those arteries at the top there. There's different ways to measure heart activity. One of the most common ones is to use something called an ECG, or an electrocardiogram. It's a recording that basically just monitors the electrical stimuli coming off that myocardium layer of your heart during a cardiac cycle, so during a contraction and a relaxation. This is a really old school picture that you're seeing here. Back in the day, we used to just put these electrodes on people's skin, and then those were connected to wires. You can see the numerous wires here, and then those were hooked up to a machine sitting next to the patient's bed. And this machine had basically a moving pen, and so every time it would get a stimuli, this pen would jump and do a recording on the paper. And this is kind of what the recording looks like, showing us the contraction of the heart occurring and the resting period between. Nowadays, this is a digital machine, so this has improved a lot. The electrodes just look maybe a little bit more simplified. It might now be just kind of more of a band that we put on instead of a sticky electrode. And it goes to a digital machine, so now this would be like on a screen next to the patient's bed. As far as I know, it still does actually do a printed readout, and that's so a doctor or a nurse can come in, even if they haven't been in the room with you the entire time. They can hold that sheet up, look at maybe the last 10 minutes of heart activity, and it allows them to diagnose any problems that might be going on with the rhythm of your heart. So this is kind of how you read it. Normal ECG patterns should kind of have this rise and fall wave going on. So the first one, this is called the P wave. And what this does is tell us that the atria are contracting. So you can see that this isn't a real strong contraction because we're just trying to get the blood down into the ventricles. So that doesn't need to be very strong. The big one that the doctors are going to look at, that's the QRS complex. And so what this one is kind of the what we call the depolarization of the fibers. So that's like the electrical stimuli coming. And then this is the big contraction of that ventricle, pushing all that blood up and out. And then this is the resetting of the fibers again after that. The T wave then is also kind of a resetting period. If you think back to the muscle unit and you remember that muscles have to reset themselves, all the little elements like calcium and sodium and things like that have to go back into their corresponding channels. And so this is the heart resetting itself. So you do actually get a little bit of an electrical stimuli happening there because everything's kind of moving back into its original position. So like I said, physicians can come in, they can look at an ECG, over the course of the last few minutes, and we can actually determine if the heart rate is looking normal or if we have some sort of issue going on there. So some things you might see, here's a normal heart rate. We have very steady, strong ventricular contractions, and it's very rhythmic. You have pretty normal resetting periods, atria contraction. It's just nice and steady, and everything kind of looks really good. Somebody with a fast heartbeat, if you notice here, we're not really allowing the heart to reset itself, or at least not very well. It's not getting long enough. And so this heart is working overtime. It's working way too fast, and that can cause some problems down the road if you don't allow those chambers to completely fill with blood. This person has a little bit too slow of a heartbeat. We might not be getting oxygen to the tissues quick enough. It's got just way too long of a resting period here. And so that can tell us that something's going on there too. And then this would be somebody with just an irregular heartbeat. A couple quick ones here, way too long of a resting period there. Then we kind of go pretty steady for a while. So this would be, maybe like a heart murmur, something's going on, telling us that the pacemaker is just kind of off a little bit, and it's not sending steady signals. So we definitely would want to look more into why this is occurring. All right. I think that covers it for the heart action notes.